Kristine Lauria is an internationally recognized midwife and has dedicated her life to supporting women's autonomy in medical decision-making and physiological undisturbed birth. In recent years, she has devoted significant time to humanitarian work with Doctors Without Borders, MSF, providing essential reproductive health care in low-resource settings. She specializes in breech and twins and travels worldwide teaching those skills to midwives. Her inspiring life and work is featured in the upcoming documentary, Allowed to Birth: The Journey of a Global Midwife, premiering this fall. So, evaluating breech options with Kristine Lauria. Kristine, if you'd like to take it from here.
Yes, thank you. So nice to be here. I will go ahead. Oh, I need you to
To allow you to share.
turn on the share. Yep.
You should be able to.
Brilliant. Okay. It should work.
And if anyone has any questions, feel free to either put that in the chat or the Q&A.
Yes, I will definitely answer any questions at the end. You can see my screen. Yes?
Yes.
Okay, wonderful. Good. So I'm going to be talking about options for breech this evening. As in the introduction, I'm a certified professional midwife. I've been practicing for over 35 years now. I spend a fair amount of time overseas with MSF, Doctors Without Borders, doing maternal infant health in low resource settings and disaster areas, conflict zones, and so forth. I also lecture and teach worldwide, primarily breech and multiples. That's what I specialize in. And I've co-authored a guide to physiological breech birth. So those are the things that make me qualified to be able to talk with you here this evening. So just to start out, for people who aren't familiar, breech presentation is when the baby is not head down and either presenting with the butt first, or sometimes it's the feet in the butt, or one foot and the butt down and then one leg up. Like you see here. There are some other more rare presentations like knees and so forth, but these are the three that are the most common, and by far they're the most common in the order that I presented them. So most babies are frank, a good majority of them, and then the others are complete or incomplete, as the third one would be. So this is what we're talking about when we're talking about breech presentation. I won't be addressing like transverse lie or anything that's completely different. So we're just discussing breech in this fashion, these three presentations, as well as term, not premature babies and not babies with any kind of anomalies, which I'll discuss here in just a bit. But just for clarity's sake, it's term breech, so 37 weeks and beyond. So people always ask when they do have a breech baby, why is my baby breech? And so there are a lot of different reasons. Sometimes it's the shape of the uterus. If you have a heart-shaped uterus, if you have it's sometimes called bicornuate uterus, a septum in the uterus, you may not know this until actually you've had a cesarean and then somebody says, oh, you know what? You have a uterine anomaly. And so this oftentimes, because of the shape of the uterus, the baby will be in a breech presentation. There's in other internal structures, the shape of the pelvis, the fascia, the musculature. So sometimes massage and things, and this is why massage and chiropractic and so forth can help move some of these babies. Stress, a lot of times we see people who are under stress have babies that turn breech just very spontaneously. And mothers will oftentimes say, that they've been under stress, or maybe there was a death in the family or something, and they can say, oh, I could feel my baby flip. I know my baby flipped because I'm just so stressed out. So although this cannot be proven scientifically, anecdotally, a lot of women would say that they believe that their baby is breech because of the emotional stress that they're having in the pregnancy. A genetic predisposition in either the mother or the father. There was a longitudinal study in Norway done back in 2008. And by longitudinal, I mean multi-generational. And it showed that women who either were breech or had a partner who was breech, either or, had twice the likelihood of having a breech baby. So if your mom said you were breech, you can have a genetic predisposition to that. It doesn't mean that your baby is going to be breech, but we do see this not it's not uncommon that we see it run in families. And all my aunties had breech babies except for one, and things like that. So we'll see that. But also it's the mother or the father. So that's twice the likelihood with that. So in terms of the baby, there can be fetal anomalies that can cause the baby to be breech. The baby could have a genetic condition, and it might not even be something we can diagnose on ultrasound, so it might not be anything we notice until after the fact. And there could be a short cord or a tight cord. The baby's all wrapped up in the cord from early in pregnancy, and now it can't turn to head down because when it turns, it causes itself stress because it's pulling on the cord, so it just stays put. And also placental placement. The placenta's in the way, and the baby is not turning because of that. And then in the vast majority of cases, honestly, we just don't know. Babies come out breech vaginally or by C-section. And we're like, did they see anything? Was there a short cord? Was there a tight cord? Is there anything? No, no answer. Uterus looks great, normal. We don't know. So oftentimes we don't get the answers that we want. So we're oftentimes unsure. So what can you do to help turn a breech baby on your own? A lot of people will do chiropractic care, acupuncture. There's something called breech release. That's a massage technique that kind of releases, as I was talking about earlier, that fascia. A pelvic tilt, anything that puts your hips higher than your head and helps the baby to turn. Some people will do handstands in the swimming pool. They'll put ice packs on the baby's head in the hopes that the baby's not liking that too much and will flip. Homeopathic remedies, visualization, hypnosis kind of things, visualizing that baby going head down. And then some people just wait and try to be patient and see if the baby will turn on its own. So basically doing nothing at all except for except for waiting. So these are some things that you can do. I'm sure I missed a thing or two here and there. That's not an exhaustive list, but it's a lot of what people will tend to do. We start to be looking at breech presentation more once we get to about 35 or 36 weeks. If we've had a baby that's persistently breech, we're not really concerned at 28 weeks. It's very normal. A good percentage of babies at 28 weeks are still breech. And again, also at 32, we're hoping by this time maybe it's gone head down, but a good amount will still at 32 weeks be breech. But by 34 to 36 weeks, we generally will see babies go head down. It's gravity makes it so that the head is the heaviest part of the body, and those babies really like to be head down, generally speaking. So it isn't until we get to term to about 37 weeks where we see about 3 to 4% of those babies that just don't turn. And that's a pretty consistent number worldwide. Not all numbers for all things in birth are consistent around the world, but this is pretty consistent worldwide, this statistic of 3 to 4%. So what are your options if the baby stays breech? So the options really are just three. You can do a vaginal breech birth, and we're going to go over all of these options in detail. You can do what's called an external cephalic version, which is having a practitioner manually help turn your baby. And then, of course, cesarean section. And so these are generally the three things you can do. They go down, if we do the external cephalic version and it does not work, then you're down to only two options. So before we talk about the options, we need to talk about how are we going to make these decisions when presented with these options? First of all, in order to make a decision about what we want to do, we need to be given appropriate information. So this is where informed decision making and informed consent comes in. And informed consent is an ethical and legal process where the your physician or midwife explains to you all of the risks and benefits and alternatives of any given procedure or treatment. In this case, it would be the three that I just listed: ECV, vaginal breech birth, and cesarean. And this is going to help you be able to make an informed decision. This information must be presented in an unbiased way. Threats and coercion aren't the way to educate patients and clients. So in order for you to make a decision on your own, you need to be educated on all of these alternatives and all the risks and benefits. So that includes a description of, in this case, the diagnosis would be breech, a breech presentation. And so what are the risks and benefits to the proposed procedures or choices? And so you need to know what all the consequences of all of your choices might be, and then any alternatives and the risks and benefits included in those as well. So your practitioner can give you a recommendation and say, you have these options. I would recommend this, and this is why. And that's perfectly appropriate. And you may go with that recommendation or you may not. But that's generally what most practitioners are going to do, is give you these choices, and then you and their recommendation, and then you make a decision. So when you need to make a decision, you have to understand all of the different aspects of the options. So we can give birth in a hospital, birth center, or home. And by the time you're at the point where you're making a decision about the breech issue, you have already probably chosen your place of birth. So then we have to look at what is going to happen beyond there, because you might not have all the choices available to you. So a surgery, ECV, a vaginal breech birth, and then a physician or midwife. All of these things are going to weigh into the decision making, right? So a midwife obviously is not going to be able to do surgery. That would require a referral. So depending on where you have started out in your journey and where you're hoping to go, you may end up changing course because of what may or may not be able to be offered in your particular circumstance with your particular practitioner. So the cesarean risks for breech are the same as they are for anything, and I'm sure you're all familiar with all of the risks. Again, this is not an exhaustive list, but we know there's a longer recovery for the mother. We know that this interferes with future pregnancies. in terms of increased risk for uterine rupture and placenta accreta and so forth. And then there's surgical complications, and then babies having respiratory issues and spending time in the NICU, surgical injury about 1%. And then the long-term health risks with cesarean being linked to asthma, obesity, and type 1 diabetes in some studies, and the breastfeeding challenges. So all the same things we would expect. And so if we are going to weigh the reasons for having cesarean, if it's a non-emergent surgery, then we want to really take a good look at these risks and how they compare to the risk of vaginal breech birth as well. But we'll talk about ECV a bit first. The risks of this are that it can have a fairly low success rate depending on who's doing it, but it's about 50%. So they may be able to turn your baby about 50% of the time. There's always a chance of a reversion. The baby turns back. Sometimes it's right away, sometimes it's later that day, and sometimes it's a few days later, but they can sometimes turn back. Placental abruption, actually doing the procedure and dislodging the placenta. It's pretty rare, but it's a risk. It's rare, like some of the complications that we see with cesarean. They're rare, but they're there. They happen to somebody, right? Umbilical cord accidents. This is why they monitor babies when they're doing an ECV. The chances of needing an emergency cesarean because of placental abruption or umbilical accidents or accidentally rupturing the membranes. All of those things can happen. And then, of course, it can be painful. They do give medications depending on who is doing it and what environment you're in. So these are generally those. One other thing that I would like to mention about ECV is that we often see, and I think there have been a few studies, I don't have links to them, but we're seeing for sure anecdotally that whether or not the baby is successfully turned head down, people who have had ECV done and kind of it requires that the baby's not engaged in the pelvis, so pushing them up more and turning them or trying to getting them part way, getting them the whole way. We see an increase in then malpresentations at the time of birth. So that means posterior babies that are head down or babies that are just not quite in the right position, causing longer labors, causing obstructed labors sometimes. And then sometimes those end up being cesareans. The same thing with breech. We try to turn the baby, or maybe we do successfully turn the baby, but it reverts. We see those babies sometimes having longer labors and having a harder time negotiating the pelvis because they've been dislodged. They were in a nice position that they chose, and then somebody took them out of that position and moved them around. It's not that they can't be born. It's just that sometimes we see that those labors are more complicated. And this is an important risk factor for people to understand because this might be something where they would choose to decline this procedure if they have this particular knowledge. So again, I don't have, it's not listed here because I don't have a link to a specific study, but we have seen it and it is talked about quite a bit in the breech community amongst breech providers. So the risks of vaginal breech birth are that there may be a higher fetal mortality rate. Now I say maybe because it's going to depend on different factors. Primarily the last thing I have listed here, which is an unskilled practitioner. And really that is the greatest risk factor. And it's very difficult to get breech skills when we only have 3 to 4% of people that are even having breech babies at term, and then we section the vast majority of those. So then if we only come across them once in a while, or only have a few clients per year that are asking or wanting a vaginal breech birth, it's very difficult to get proficient at vaginal breech birth. So we can also see higher NICU admissions, risk of cord prolapse, a little bit higher than we would have for a head down baby, particularly if the baby is in a non-frank position. The second two that I mentioned, the complete or incomplete, those have a bit higher risk of cord prolapse. It may or may not be an emergency with a breech baby, though. So, and then we do see some lower APGAR scores. Babies tend to tell us through their APGAR scores when they've been born breech vaginally that it wasn't so terribly fun for them. They generally recover fairly well by the 5-minute APGAR score, but the 1-minute APGAR score tends to be lower than their cephalic counterparts. So questions that you should ask if your baby is breech is what type of breech baby do I have? A lot of people aren't sure. So the ones that I named, they will tell you, oh, well, the legs are up. The legs are up by the face. And so your baby's frank, or your baby is in a crisscross applesauce position. That's the complete, or one leg up and another down, incomplete. So, and am I a good candidate for ECV? Am I a good candidate for vaginal birth? Do you have experience with ECV? Do you have experience with vaginal breech birth? All of these things are what you're going to be wanting to ask your physician or midwife. Can you give me a referral to somebody who does have this experience? If they say, well, no, I don't do ECV, or no, I don't. Obviously, a midwife is not going to be able to give you surgery, so they would need to refer you. And if you have somebody who doesn't have experience with vaginal breech, you would want to ask about what colleagues they have that they might be able to refer you to. And so it's not unreasonable to ask for a referral because it is a specialty. At this point, it shouldn't be. It should be standard in obstetrics that everyone is trained in vaginal breech birth, but sadly, it's not since the late 90s, basically, and certainly since 2000. And if you are choosing to have cesarean, or you can't find someone to attend you vaginally, and you decide, okay, I'm having a cesarean, then can I go into labor spontaneously rather than scheduling a cesarean? They like to schedule the cesareans just because, it's just nice. Show up this day at this time, and they have it on their schedule. Rather than padding in at 2 a.m., not as much fun. That is not an emergency cesarean. They will say, well, no, we like to do this because we don't want to have to give you an emergency cesarean. You going into labor spontaneously is not an emergency in and of itself. And so walking in labor and then having a cesarean is perfectly reasonable and does not constitute an emergency. It's just an unplanned cesarean. You knew you were going to have it. It's just unscheduled. So it's planned. It's just not planned for. We don't know when it's planned for. We're letting the baby decide. And the benefit of this, there's two benefits to this. One is that there is a small amount of babies that they get to labor and they have changed their position. And this happens not infrequently. It happens fairly often. People tell me, oh, I was going to attend a breech and then the baby turned at the last minute. I just saw her 3 days ago and I went in labor and the baby was head down. And I said, just imagine if they had sectioned her 2 weeks ago. So this is a good reason to wait, okay? you're not risking anything. There is not a risk carrying a breech baby until you spontaneously go into labor. And it's always nice to have the baby choose. And it's always nice we know the benefits of to you and the baby to get at least a little bit of labor in, at least some for the baby to feel some of the stress of the contractions. We know that we're hardwired to really need that for survival. We can survive without going through labor as a species, babies, obviously, we do, but we know that labor is beneficial to babies. And so those are two very good reasons to not schedule a cesarean, as convenient as it sounds for everybody. Um, it is definitely worth waiting, because your baby may well uh, change to head down. Some of them just wait until the very last minute. And so just keep that in mind. So who is a good candidate for ECV? So you have to really ideally be not too much more than 37 weeks, just because the baby's getting a lot bigger, and they're a bit easier to turn, and they're less likely to be engaged in the pelvis then, because that's another reason that it wouldn't be successful. The baby's engaged. You want to have adequate amniotic fluid. If you're on the low end with the amniotic fluid, it's harder to turn the baby. We want just one baby in the uterus. If you have multiples, we're not going to try to move multiples around. So they're going to stay where they are. So a singleton pregnancy, a nice relaxed uterus. So not a uterus that's hypertonic, which is sometimes why they give medication if you're having an ECV in a hospital. They'll give medication so that the uterus isn't contracting and the baby's able to move. And your membranes need to be intact. So, and likely they would be if you're just going in for an appointment for an ECV. Um, so who should not have an ECV? Again, somebody that has more than one baby in their uterus, somebody that has a baby that has fetal anomalies. Again, if it's a cleft palate that they happen to see, yes, it's an anomaly. Nothing that would keep a baby from being able to turn. So it would be more gross anomalies. And then a uterine anomaly, a bicornuate uterus, septum, those types of things. Potentially, and depending on where they are, fibroids, not always, but sometimes. And placenta previa, your placenta's down really low. You're probably not going to want to be doing an ECV then, because if you dislodge that placenta, it's down low. There will be problems with bleeding. And then anybody that has any kind of bleeding issues, if you've had any spotting during the pregnancy on and off, and they've been monitoring that, you probably won't want to have an ECV. They likely would not do one. Who would be a good candidate then for vaginal breech birth? If you were already planning to have a vaginal birth, and there were no contraindications, then you are likely a good candidate then for a vaginal breech birth with your practitioner. Again, we're talking about full-term pregnancies, not preterm. And that's a different subject, still possible to do, but it's a different, deeper conversation. A baby, again, with no anomalies, no gross anomalies, no growth restriction. If we have an asymmetry in the growth, so the baby's body is smaller and the head is bigger, that would be a contraindication to a vaginal breech birth. And you really want an experienced provider to attend your birth. So you might be a good candidate, but as good as you are, your practitioner has to also know what they're doing. So that is one of the bigger hurdles. So I am more than happy to take any questions that have come up, and anything that I missed.
While we give everyone an opportunity to type their questions either into the chat or the Q&A. I have a question. You said you also specialize in multiples. What about when you have twins and one of them is breech?
Yes, so when we see twins, about 45% of them are going to both be head down. So it doesn't even happen half of the time. So it's really unrealistic for any practitioner to say, I'll attend your birth vaginally as long as both of your babies are head down. It's ridiculous. We have two people inside of a uterus vying for space. They know what position they need to be in. It's not an accident, the positions that they choose. And so it's definitely an issue because, again, practitioners are because they're not trained in breech, they often use it as an excuse if one of the babies is breech, particularly if the first baby is breech. I'll do it if the first baby's head down and the second baby's breech, we can do an extraction. Or sometimes they will even do a head down vaginal birth and then go back to the OR if the baby is breech. And just, it's really very unfortunate that they do that because if they have a skill, think of the skill you have to be a surgeon. Like, I do not have that skill, right? And they can't attend a birth vaginally. Why? So there is training out there. They're just not getting it. And so it really is a failure of the system that we're not training all of our medical students and all of the midwives, CNMs and CPMs, everybody across the board in breech birth because it happens enough that it should be something that is taught.
I guess, how did you come to start attending breech birth and kind of specializing in that?
Sure. Yes, so I did my apprenticeship many years ago in an Amish community, and I have attended breeches and multiples since my apprenticeship. It was not something that was, oh, this is really dangerous, and we got to be. It was just something that needed more skill. It's something that you did need to understand before you jumped into it, but it's something that I've always done. And so then once I finished my training, I moved to another state, and the midwives there weren't trained, so they sent me all of their people that were breech, and I also attended a lot of multiples, and that still happens here around in different states. There will be little pockets of a couple midwives here and there that get all of those breech babies and get all of the multiples that are out of hospital because those midwives have those skills. And so that's the beauty of that. But that's how I got it. And now I go to places where I do a very high volume of births. In Afghanistan, for example, I was doing 25 breaches a month. So I've done hundreds and hundreds of breaches. And so, I consequently have pretty good skills in breech.
So you have a few more questions now. So
Okay.
the different variations of breech, frank breech, complete breech, and incomplete breech, are some of them a higher success rate with vaginal birth than other of the types of breech? Which ones are easier and which ones are more difficult?
Yeah, so that's a good question. Frank Breech seems to be considered the easiest, just generally the one that's the least problematic. And so I would have to say, and usually physicians and in places where they will in hospitals occasionally agree to doing a breech birth, they'll do it if it's frank. They won't like the other presentations as much. And again, it's because sometimes a foot will drop down or feet will drop down. They don't like that. There's a higher incidence of cord prolapse, up to 15%. So they don't want to take that risk. And so I would say that frank is the preferred. Just in general, although I know plenty of midwives who like doing completes and incompletes. I really don't mind any of the presentations, but I would say that sometimes the non-franks will fail to descend well into the pelvis. And so they, at least for me and from what I observe, and for me, for my own, I've only sent a few personally to cesarean, and all but one has been frank. Or they were complete. The one was frank, and the rest were in complete or incomplete positions.
So is cord prolapse the biggest concern with breech? Can you talk a little bit more about cord prolapse and breech?
Yeah, so I wouldn't say it's the biggest concern. There's a higher rate of cord prolapse with breech because you don't have a nice round head blocking the outlet, right? And so also the when you think about it, where the cord is located, it's lower down on the body, and the body's lower down, and that cord can, if when the membranes release, if that baby isn't fixed well down into the pelvis, the cord can come down with the water. But again, it may or may not be an emergency. It can be if the person isn't already pushing, completely dilated and already pushing. But if they're pushing and you get a little foot and then you get a little cord dangling there and they're still pushing, the birth is happening. It's happening, and it's likely not going to be a problem. But if it comes down earlier in labor, then yes, that can be an issue that needs to be managed. But as I said, the incidence of that is somewhere between 5 and 15% with the non-franks. With franks, it's the same percentage as with a head down baby, 0.5%.
So someone saying that they're often counseled that with a footling breech, which is synonymous with incomplete breech, correct? That C-sections are often required by practitioners for footling breech. Do you see that at all in your experience?
Yes, so yes, because they're mislabeling a complete or an incomplete. Really, what they're talking about, if we're talking at term, it's not a footling breech. They're calling it that, but it's not. It's just a baby that was sitting crisscross in and then dropped a foot down. And then they say, it's footling. No, it's not suddenly footling. The butt's right there. The foot just dropped down. The butt's on its way. So yeah, they will use it as an excuse to do a cesarean. Again, because they're worried about cord prolapse. But if the feet are there and there's no cord and you're listening to the baby and the baby sounds fine, there's no reason not to continue with the birth.
Can you speak a little bit about how midwives, or I guess anyone would get training to attend vaginal breech births?
Yeah. So there are different organizations out there depending on where people are. You might have to travel for training. Breech Without Borders does training. There's an online 15-hour online course and then a full day hands-on workshop. And they train midwives and physicians. They train in hospitals also. Stuart Fishbein has Reteach Breech, and he travels. And if you look up Birthing Instincts, he travels and will actually uh, teach midwives and physicians as well. It's a 2-day workshop. Nicole Morales has her Breech Basics that is an in-person class, and then also she has the Breech Release, which is a class about a lot of the different massage techniques to help for babies to turn on their own. So there are those are the biggest ones I would say that are out there. And then there are I think there are in other countries they have like in Australia they have their own course Babe, and then Opti Breech in the UK. So there are places where training can be had. There's no reason why a practitioner can't get trained at this point in time because there are plenty of choices.
How about if someone is a midwife that would attend a vaginal breech birth, but there is resistance from obstetricians in I guess at the hospital or practice where they work, how would they go about, or how would someone that is wanting to have a vaginal breech birth go about convincing a care provider to be open to that possibility so that it's more normalized?
Yeah, so the in a hospital situation,
Uh, this actually doesn't specify, but
okay.
yeah.
Yeah, I mean if you're talking about in a hospital, it's you need somebody that knows what they're doing. It's not about convincing, it's not safe for you or your baby to have an unskilled practitioner attending you. So this is why it's best to ask for a referral to somebody that does have the skills that you want if you're looking for ECV or vaginal breech birth, if they're not able to do it in your own hospital with your own practice. And it's just because, I mean, I've read online people saying, oh, don't let them do surgery. Just wait until you're in labor and go in labor and then just refuse the surgery. That's not really a good tactic because this is where we do see an increase in the mortality rate with breaches. This is what makes breech birth dangerous. An unskilled practitioner, that's the single greatest risk factor with any breech is the practitioner. So if they don't know what to do and how to do it, your baby is definitely at greater risk. And then that's where we see that higher mortality rate because we know that the statistics are good and that's why I wrote, it may increase the risk. It may, depending it's going to depend on your practitioner and if they know what they're doing and have the skills to be able to manage the breech. So this is why we can't take it lightly. There is no way to predict which babies are going to be complicated at the very end because that's when it happens. There is no real predictor with the labor, like, oh, if the labor does this, it's not going to be good at the end. There's just no way to predict. They can have a perfectly fast 4 hours labor, they're pushing for 20 minutes, and the baby starts to come, and it could be very complicated. What happened? Why? What? It's just because it's breech birth. There's no way to predict. And conversely, we could have a very long, slow labor. We've been pushing for a couple of hours, and here comes the baby, and whoop, 30 seconds, it's out. And you're like, wow, that was easy after that big, long labor. So there's no way to predict. If there was, it would be much easier for all of us, trust me.
Yeah.
So, this is the problem, is the unskilled practitioners.
How about, are there maternal comorbidities that would pose a risk for vaginal breech birth, such as prenatal gestational diabetes or hypertension?
No, again, if we were going to have a vaginal birth, if the baby was head down, then it should not really affect that in any way.
Um, do you notice a difference in the breech presentation between primipara and multiparous women?
No, it doesn't, there doesn't seem to be a difference in how they present. Uh, I think, I think it's just fetal preference. But no, there doesn't. And even people who are serial breech birthers, I call them, I have one friend who she's had 7 breech babies and 1 head down baby, and her babies have been all different. So none of they, I mean, there's only basically the 3. So, but they've been different and mixed up every time. So there's just not any way to predict exactly how they'll be.
Okay, I think that is all the questions.
Okay.
Unless anyone else has any questions. I want to thank you very much, Kristine, for your time.
Sure.
And I would like everyone else, everyone on the call to want to thank you for following ICAN. Feel free to check out our website, attend local meetings, and thank you very much for participating in Cesarean Awareness Month this April. Thank you so much.
Thank you.
And the recording of this will be available on our website, hopefully in the next week or so. And it should be available for several months.
Wonderful.
Thank you very much.
Thanks.
Have a good night.
All right.